All right, we're going to do things a little differently today. This isn't just an explainer, it's a simulation. You are the surgical candidate, and I am your examiner. This is it. This is your consultant Viva exam. And what you say in the next few minutes could define your career. No warm-ups, no easy questions. We're diving right in. Your first patient is waiting, and they are critically ill. Let's see how you handle the pressure. Okay, here we go. Your first case is a true emergency. A patient has just been rolled in, and frankly, he's not doing well at all. So, listen very closely. So, you've got a 39-year-old male, right upper abdominal pain, fever, and jaundice. Your brain should already be screaming Charcot's triad, right? But the most important detail is that last one. He is hypotensive. That changes everything. This guy is in shock. He is right there in front of you. The nurse is looking at you, waiting for your orders. What is the very first thing you do? Your time starts now. Okay, the only correct answer here is to resuscitate before you investigate. You have to go straight to the ABCs: airway, breathing, circulation. He's hypotensive, so that means 2 large-bore IVs and a fluid bolus are your immediate actions, not asking about his family history. Only after you've started resuscitation do you begin to draw blood and take a history. Getting that order right is absolutely crucial. All right, good. You've started fluids, and his pressure is improving just a little bit. Now you can get the details. Your history and exam confirm what's on the screen. Stabbing pain for 5 days, classic signs of jaundice with dark urine and pale stools. His vitals are still pretty scary. A fever of 39 degrees, a heart rate of 110, and he's still hypotensive at 90/60. But look at that key physical finding. A tender right upper quadrant, but with a negative Murphy sign. What's that little detail suggest to you? Good. He's responding to your initial moves. You've got a working diagnosis forming in your head. What's your next step? What investigations are you going to order to confirm what you're thinking? Your labs come back. Take a quick look at this table. There are several things wrong here, but one number should immediately just jump right off the screen at you. Yeah, that one, a white blood cell count of 22,000. This confirms a severe infection. This man is septic. You also see a cholestatic picture. His bile flow is blocked with that high bilirubin, and a little bit of a transaminitis, which is a sign of liver inflammation. The picture is getting crystal clear now. And this is the smoking gun. Your ultrasound gives you the final pieces of the puzzle. You've got stones in the gallbladder, the bile ducts are all dilated. And there it is. The common bile duct is 9 millimeters wide and it is filled with stones. You have your source. So your diagnosis is acute ascending cholangitis. This is a life-threatening surgical emergency. It's caused by an obstructed and infected biliary tree. And this patient has the full Charcot's triad: the fever, jaundice, and abdominal pain you picked up on right from the start. You have your diagnosis. The patient is still incredibly sick. What are your definitive management orders right now? Be specific. Correct. This patient needs to go straight to the ICU. You'll keep him NPO, nothing by mouth, and continue with aggressive IV fluids and broad-spectrum antibiotics. But the most critical, life-saving step is urgent decompression of that biliary system. You need to get GI on the phone for an emergency ERCP right now. But the exam is never that easy, is it? Here's the twist. GI performs the ERCP. They pull out a bunch of stones, a lot of pus, but one large stone is impacted. They just can't get it out. After the procedure, the patient's bilirubin is still rising. Your first-line treatment has failed. What's your next move, surgeon? This is where the surgeon earns their money. When endoscopy fails, surgery is the answer. The definitive management is to take the patient to the operating room for a cholecystectomy and a direct exploration of that common bile duct to remove the impacted stone. Very good. You've managed a critically ill patient. Now, let's change gears completely. Your next case isn't an emergency. It's an investigation. It's a puzzle that's been developing for months. Okay, a 51-year-old man. He's got some vague abdominal pain for 6 months. But here is the major red flag: a 20-kilogram weight loss. That is a massive involuntary weight loss. Your alarm bells for a malignancy should be ringing off the hook. So here are the potential causes. Now, while it could be something benign like chronic cholecystitis, a history with that much weight loss forces you to put gallbladder cancer at the very top of your list. You suspect cancer. What is the correct and, just as importantly, the safe way to work this patient up? What specific investigations are you going to order to get your answer? Your workup has to be precise. You need high-quality imaging, specifically a triphasic CT scan with a liver protocol to really characterize this mass and look for any spread. You'll also check tumor markers. Now, crucially, as the slide notes, you generally want to avoid a biopsy if the imaging is highly suspicious and the tumor looks resectable. Why? Because you run the risk of seeding cancer cells along the needle track. Your blood tests come back, and this really strengthens your suspicion. The tumor marker, CA19-9, is significantly elevated at 300. This is very strong support for a diagnosis of a biliary tract cancer.
So how do you manage this? This requires a methodical team approach. First, you get full staging with a CT of the chest, abdomen, and pelvis. Second, this case must be discussed in a tumor board with oncologists, radiologists, and other surgeons. If there's no evidence that it has spread, the plan is for a major operation, an extended cholecystectomy. This involves removing the gallbladder, part of the liver, and the regional lymph nodes. A critical step during the operation is to send the cystic duct margin for a frozen section, an immediate microscopic analysis, to make sure you've completely removed the cancer.
Okay, exam paused. Let's just step back for a second and analyze what these two cases have taught us about thinking like a consultant surgeon. This slide really sums up the core lesson. Case 1 was all about urgency. The priority was resuscitation and speed. You had to know your algorithm and your bailout options when the first plan failed. Case 2 was all about strategy. The priority there was meticulous planning, staging, and a careful, oncologically sound operation. You had to know your decision points before you even walked into the OR. Two completely different mindsets for two problems in the same part of the body. And that brings us to the end. I'll leave you with a final question that really is the essence of any high-stakes oral exam. You've presented your perfect plan, and the examiner says nothing. They just look at you. That silence? It's a test. It means you've probably missed something. Post-operative care? Follow-up? Potential complications? The best candidates are always thinking one step ahead. What else is there? That's the question you must always be asking yourself. Exam concluded.